Welcome everyone to this webinar on the treatment of lupus nephritis and ANCA-associated nephritis. My name is Marten Segelmark and I'm professor of nephrology at Lund University, Sweden. This webinar has been proposed and conducted by the Immunology Working Group, the IWG, of the ERA-EDTA. You can all become members of this working group for free if you are EDTA members, and then you will receive a very interesting newsletter on a regular basis, and you can also benefit from the homepage and to participate in many of the other research activities conducted by the work group. Also, if you are an ERA-EDTA member, you can receive a CME credit point for participating in this seminar live. And the speakers for today that we have on the subject of novel treatment options for lupus nephritis and vasculitis in 2021 are Hans-Joachim Anders from Munich, Germany, and Annette Bruchfeld from Linköping in Sweden. We also have two panelists who will comment and ask questions later on, and that is Kültigin Turkmen from Ankara, Turkey, and Dimitrios Goumenos from Patras, Greece. Today is actually a very special occasion for me, as this is my last duty as vice chair of the Immunology Work Group, and what could be more appropriate than to hand over the word to the new vice chair of the organization, Hans-Joachim Anders, please.
Okay, so I hope now you can hear me. And I can gain back control on my slides. Okay, so treatment of lupus nephritis is certainly something that requires control of SLE. And here just put you one example of autoimmunity in general. So autoimmunity can have a constant baseline autoimmune activity, and this is mainly determined by the clones of autoreactive cells in spleens and lymph nodes. And it can occur in flares. And we know that very well, that in each patient can be different from another. Some patients have an ongoing persistent immune activity. Others present more in flares and intermittent disease activity. And to control this, we need disease-modifying drugs that are able to control these autoreactive clones in spleens and lymph nodes. On top of that, patients with lupus nephritis may also benefit from treatments that act on the kidney itself. This may be anti-inflammatory drugs, but this may also be drugs that reduce hyperfiltration, for example, or have specific effects on the glomerular filtration barrier. This is something we do not necessarily expect from immunosuppressive drugs, but this may also help to reduce kidney injury and damage that accumulates over time. So in this 15 minutes lecture, I picked up only the two drugs, belimumab and voclosporin, which have recently been approved for the treatment of lupus nephritis, at least in the US, voclosporin, belimumab already also in Europe. And that's why we focus on the clinically relevant parts today. So what is belimumab? Belimumab is anti-BLyS. BLyS is a B-cell, B-lymphocyte stimulating factor, so a cytokine that activates and drives B-cell proliferation. And anti-BLyS, so belimumab, is administered once per month as an intravenous application or once per week subcutaneously. Both are approved for the treatment of non-renal SLE. And the new approval now is also for the treatment of patients that have primarily lupus nephritis. But due to the 13 years time period where belimumab is already approved for the treatment of non-renal lupus, there is already a lot of knowledge in terms of safety and efficacy on these kind of patients. And certainly many of these patients had also some sort of renal involvement. That's why here we have a lot of information about how to use the drug and who benefits and who doesn't. The drug is characterized by a slow onset of clinical activity, so it takes a while up to things improve, a bit similar to hydroxychloroquine, but the mechanism of action is to suppress immune activity, probably mostly in the lymphoid organs. Some people say that it also has a direct effect on B cells inside the kidney and inflammatory infiltrates, but the main concept is that it acts systemically. It is known to reduce the number of disease flares, and due to that, you have less damage accumulating over time, which is certainly important in terms of the kidney, because preventing CKD progression is one of the main treatment targets in patients with lupus nephritis. Belimumab has a good safety profile, although there were some hints in some of the studies that may aggravate depression or induce suicidal thoughts. And that's why in the following studies, this was carefully looked at. And in the first trials, it was also noted that patients on belimumab had more pregnancies, which was thought they are in so much better condition. But still, the label is not to suggest belimumab treatment during pregnancy. So the trial that led to approval recently was the BLISS-LN trial, and this is summarized here on this graphical abstract. So it was the largest trial on lupus nephritis ever been conducted. And already this is important. It's obviously a trial conducted all over the world. Half of the patients were from China or from Asia, let's say. A minority of patients was from Europe, we have to admit. And there was the usual gender or sex distribution that we know from such lupus trials. Only one patient out of 10 was a male. The randomization was 1-to-1, and the primary readout was at 2 years. The secondary readout was at 1 year, and the primary endpoint was a score that basically looked at proteinuria, serum creatinine, and the use of rescue therapy, basically steroids, which was not allowed to reach the primary endpoint. And as you can see here, there are more patients in the belimumab group reached these endpoints. The complete renal remission was a very tough in terms of proteinuria. Only 500 milligrams per day were allowed. In the partial remission, 700 milligrams per day. So pretty tough, especially for those patients starting with high proteinuria levels. So here you see the distribution over time of patients reaching this endpoint, and you can see that starting from 6 months, there was a gap between the two groups, and this gap basically persisted over time, a bit unusual because we would have expected that the gap would increase with time. This didn't happen, so that means the patients that benefit, you can recognize after 6 months or 10 months, but there are not more patients benefiting from belimumab later. So it's really something that can be decided. If a patient doesn't benefit from belimumab after 6 to 8 or 10 months, then less likely to benefit also in the future. The important endpoint is the probability to renal-related event or death, which is sort of a marker of disease progression or also to disease flare or relapsing disease activity. And you can see here that already after 8 weeks, there started to be a difference between the two groups, and this was maintained over time and even increased a bit with time. So I think this is a very good argument, because having flares of lupus nephritis is certainly one of the major drivers of CKD progression in those patients. Okay, in terms of safety, there was no particular sign, no unexpected result, or no new signal. That's why this safety data fits very well to the data that we have for belimumab for the last 13 years from all the non-renal lupus trials, and was rather confirmative that this is a safe drug. Okay, so let's come to voclosporin. Voclosporin is a bit different. Voclosporin is a calcineurin inhibitor, or at least is said to be a calcineurin inhibitor to have similar activity like other calcineurin inhibitors. And you may remember that cyclosporin has a negative effects on MMF metabolism, and this was not found for voclosporin, so may have some benefits in terms of also the context of the co-medication. But as we know, calcineurin inhibitors have also a local effect on the filtration barrier, on the podocyte cytoskeleton structure. And this may be a reason here and there to give cyclosporin or other calcineurin inhibitors for proteinuria kidney diseases. And because they have a particular potential to reduce proteinuria, which you can imagine in these usual endpoints for lupus trials is a benefit. So voclosporin is being given twice a day. At this dose. The main difference to belimumab is it's not approved for any other disease so far. So we don't have safety experience or any other experience from other patient cohorts so far, at least not at the stage of approval. There was a phase 2 trial, the Aura lupus trial, that was published 2 years ago, that was positive, obviously, and gave the rationale to conduct the phase 3 trial. And maybe here one may mention that in China, lupus nephritis is usually treated in the TAC-MMF combination. So something that we haven't done so far because there was no data on this kind of constellation in European patients. But there may be some positive hints for such a combination MMF calcineurin inhibitor from other parts of the world. And what is interesting is voclosporin is said to have no metabolic side effects, especially those that we know from tacrolimus or cyclosporin. And it may also have no direct effect on, no vasoactive effect on GFR, like we know from these other two drugs. So the efficacy data is shown in this table here. It's not so illustrative like what I could show you before, but what you see here, the p-values are all highly significant. And you see here, these are mostly 1-year data with also secondary endpoints with analysis at 6 months. And as usual in these lupus trials, the primary endpoint is largely biased by proteinuria. And that's already shows what was expected, that voclosporin has a potent effect on proteinuria. And if you see here in this curve, that this difference starts very early, already after 1 month. There is a difference between the two groups. That means voclosporin, in contrast to other immunosuppressive drugs, seems to have a very rapid effect on proteinuria, and this fits well this mechanism of action of the local effect on the filtration barrier. So this effect was consistent and also increasing over time. So you could imagine that maybe a local effect then joins a remote effect of immune modulation later in the treatment course. This forest plot here shows that in whatever subgroup you look at, this is on the side of favor voclosporin therapy. So it seems to be quite consistent across these different parameters that are all listed here. And this is reassuring. What is interesting, and this I want to show you, is here a table of the supplement. Not so easy to achieve if you don't have a subscription to the Lancet, but here you find the effect on the complement levels and on the anti-DNA levels, which are the biomarkers of the SLE activity. And here nothing was significant. So this kind of questions a bit that voclosporin has really also an immunosuppressive effect because none of these biomarkers that would indicate clone size maybe of these autoreactive lymphocytes and also the systemic immune activity was significantly affected, but it was obviously very strong affecting proteinuria. So this would rather suggest that the effect is more on the kidney itself rather than on spleens and lymph nodes, which is the strength of many of the other immunosuppressive drugs that we use in this context. Again, the safety data were very good, no major signals. This is reassuring to the data that were available from the phase 2 trial. Mortality, especially in this trial, was not sort of worrisome. That's why I think from that perspective should be an interesting drug. So what I want to leave you with is now how the landscape of lupus nephritis is changing. You know that we had this idea of the induction and maintenance treatment, a concept that came from oncology, a concept that came from the use of cyclophosphamide, something that we couldn't go on in a permanent manner. But now it's more than 10 years that we treat patients with MMF. And already there, we kept patients on the same kind of drug from the beginning to the end, right? So this idea of induction and maintenance was already a bit questioned by the use of MMF in many patients. And as you can see here, the BLISS-NN trial with belimumab, the Aurora trial with voclosporin, and I don't go into details of the Nobility trial with obinutuzumab, another anti-CD20 treatment that gave positive results in a phase 2 trial. Shows you that these are all combination therapies that are continued from the first day up to 1 or 2 years. So there is no more induction and maintenance, maybe if you think of the steroids, but of course, in a disease like this, we give them a quick shot of anti-inflammatory treatment to suppress inflammation as fast as possible. But then we basically will now treat lupus nephritis like we treat patients with alloimmunity, patients with kidney transplantation. You give them a combination therapy from the beginning onwards. And I think this now is, these data suggest this concept that lupus nephritis, I mean, autoimmunity should simply be treated with alloimmunity. You need a combination of drugs that target the complexity of the adaptive immune response, but there's no need to treat patients differently in the first 3 months and then in the subsequent disease phase. So this is what we learned from these trials, that it really is a new paradigm that lupus nephritis needs a combination treatment of drugs with synergistic effects. So to summarize, the BLISS-NN trial was the largest lupus nephritis trial so far, so I think we can trust the data. It reached all its primary and secondary endpoints. We are very reassured about the safety of this drug, what we know since 13 years from the SLE experience. And this is certainly a drug that is not very fast, but it's a good stabilizer of the disease. It reduces disease activity and prevents disease flares. This is very important for patients with lupus nephritis, because each flare or relapse of lupus nephritis will kill nephrons and will promote the CKD progression on the long run. Voclosporin is a completely different drug. It has strong antiproteinuric effect. It has a potent effect in the kidney, obviously, has also a good safety, which is good news. Whether it has the expected strong effect also on the immune system in spleens and lymph nodes, I don't know. We have no data yet on flares. So seems to be the ideal combination partner for belimumab, actually. And then, of course, here one should also mention Sglt2. All lupus patients, lupus nephritis patients are CKD patients. Sglt2 inhibitors are now approved for CKD treatment. I don't know if we need an extra trial for this also to show that in lupus nephritis, but I think many of our colleagues will treat patients with lupus nephritis, also with an Sglt2 inhibitor. Thank you.
Thank you very much, Achim, for this very nice and comprehensive talk. I would like to remind all the listeners that you can ask questions using the bar at the bottom of your screen where it says Q&A, and there will be a Q&A session at the end of the webinar. Now it's a pleasure for me to introduce the new chair of the Immunology Work Group, Annette Bruchfeld from Linköping and Stockholm, Sweden.
Thank you very much. So I will talk about the novel treatment and trials for ANCA-associated vasculitis. These are my disclosures. So I've been told by the moderator that I shouldn't talk about mechanisms, but I only want, if you want to read a really good article about ANCA vasculitis, you should read this one about by, I think, my co-chair in the Immunonephrology is also a co-author. It's really a good paper. So, and I also want to just say that considering how long we've been treating patients with the old drugs, this is already publication. Anthony Fauci was published this in 1973, the first 17 patients treated with cyclophosphamide, and it's a really long time. And Things have been a bit slow in this field, but now I think they're moving faster. And these are landmark trials for induction and maintenance. And I will talk about the newer ones after 2020. Just a few words about Pexivas. So the challenges for the new studies or treatment in general for ANCA-associated vasculitis is the premature mortality. Around 10% of patients die within 12 months of diagnosis, and that treatment-related infection is the leading cause of mortality and not vasculitis, which speaks to the toxicity of the treatment. We have patients, our patients have a high relapse rate, 30 to 50% suffer relapse over 5 years. And relapse in itself is associated with cumulative disease and treatment-related damage. Also, prolonged maintenance therapy to reduce the risk of relapse is a problem because you have these continuous toxicities in many cases. And to set the screen for this is that steroids are a major cause of long-term damage. So there is, of course, a lot of disease-related damage, but steroids is a big problem with a number of well-known side effects. So the new studies that I will discuss is the ADVOCATE trial, a little bit about the MySAC trial, Rituximab, and also a few words at the end about Pexivas. So the background for the ADVOCATE or Avacopan trial is the role of complements in this disease. So complement C5a drives neutrophil activation in ANCA vasculitis, and animal models have shown that if you knock out this or treat the animals with an antagonist of C5a receptor, you abrogate vasculitis in this model. And Avacopan was developed as a highly selective orally administered inhibitor of the C5a receptor, and there was the previous clinical trial data, the CLEAR trial, the phase 2 trial that demonstrated that Avacopan had the potential to replace glucocorticoids and improve control of renal vasculitis. So this is from the CLEAR trial that here you can show, we can show that patients were treated with standard of care, high dose prednisolone in combination with cyclophosphamide or rituximab. Another group with Avacopan with low dose prednisone, and a third group with no prednisone. And the vasculitis activity score was improved for patients who were treated with Avacopan. Also, the urinary albumin creatinine ratio was better in this group, and there are a number of health-related quality of life items that were also better for patients treated that were not treated with high-dose steroids. So this phase 3 ADVOCATE trial was conducted in multi-center in several continents. And this was a randomized double-blind, double-dummy active controlled trial in patients with new or relapsing active ANCA-associated vasculitis. And this trial also included children, which is very unusual for a vasculitis trial. So there were two endpoints, primary endpoints. One was remission at 26 weeks, which was based on a BVAS of 0, and the patient had to be off glucocorticoids for 4 weeks. And then sustained remission at 52 weeks. And the two groups were, this was a large trial, 160 patients in each group. And the investigator could choose if they wanted to use cyclophosphamide or rituximab. And the Avacopan group received Avacopan 30 milligrams, twice daily, whereas the standard of care group received Avacopan matching placebo twice daily, and then prednisone 60 milligrams per day. This had to be tapered over 20 weeks to 0. So it was a trial with lots of patients and very similar outcome in with regard to withdrawal and completion and death in both groups. So these are the primary endpoint, and this is the 26-week outcome. The both arms. It was avacopan did better for non-inferiority as compared to standard of care with prednisone, but was not superior to standard of care. Whereas at 52 weeks, avacopan was significantly better for non-inferiority, but also for superiority. This is just a slide of the glucocorticoid use. You can see here that the patients with avacopan actually had some treatment at the beginning. You had to taper it all by 4 weeks, but altogether the avacopan treated patients had much lower doses than the standard of care group, which was of course according to protocol. This is, I think, actually the most interesting slide because it looks at improvement in eGFR with renal disease at baseline. And you can see here at week 26 and week 52 that avacopan is significantly better at both time points in improvement of eGFR. And this was true for patients with fairly good renal function, but also for the ones with the lowest tertile baseline GFR 21, that you could actually save more renal function. This is looking at the relapse risk and safety. So avacopan was better at preventing relapse than the prednisone arm during the course of the study. Significantly, and there were no major safety signals for avacopan treated patients as opposed to standard of care. So the results, the summary is that avacopan was superior to glucocorticoids for sustained remission at week 52, and also not inferior at week 26. The secondary endpoints is then that avacopan reduced glucocorticoids use, and also the toxicities. There was specific toxicity scheme that you had to fill out, and it also significantly improved recovery renal function. So this is a new drug that may fulfill this unmet need of eliminating chronic or large doses of glucocorticoid, and then also lead to a long-term, better long-term outcome than the current standard of care. And the current situation for this drug is that it has been narrowly approved by FDA, but there needs to be more information. And I think the approval in Europe is still pending. They're still investigating the EMA. So we'll see when and if we can use this for our patients. So MyPsych is a study that has been going on for a really long time, but was more recently published. And these are 140 newly diagnosed patients that were randomized to cyclophosphamide or MMF. And this was basically a UVAS trial. And this trial showed that MMF was non-inferior for remission induction, which was the primary outcome. For other results, there was more glucocorticoids given in the MMF arm. I don't know how that came about, but perhaps people felt unsure about the effect of MMF and they tapered it more slowly than you were supposed to. And also there was a high relapse risk with MMF that was significant, but exclusively in the PR3 positive patients. The safety, the serious adverse events were not significantly different between the two arms. You had a number of infections as would be expected, but they didn't differ between the arms. So there's a progress in this field, of course, but we still have outstanding issues. We have relapsing patients. What do we do with them? We know that Rituximab is a good induction therapy that has been compared to cyclophosphamide and is frequently used also as induction as first treatment in many centers. But what happens then? What do we do after we have successfully induced our patients? Looking at maintenance. So there have been a number of maintenance trials looking at Rituximab versus azathioprine, and these are mainly from France, and they're main RITSAM 1, is the results from here showing that new patients were randomized to maintenance with rituximab or azathioprine, and here you have the probability for relapse was greater in the azathioprine group. And then the French group has continued with different variations on this type of trial. But what you can say about this in general is that as long as you continue with the rituximab, the patients remain basically in remission. But as soon as you finish, they will relapse. The group that relapses will relapse. So what are the advantages versus disadvantages with rituximab? So it's a good drug for relapsing disease. It's better from the point of view of fertility as opposed to cyclophosphamide, and also for malignancy, and it's well tolerated. The disadvantage is the high risk of hypogammaglobulinemia in the long term, late onset neutropenia that happens in around 10% of patients with increased risk of infection, and then the humoral immunodeficiency because of the B-cell depletion. And I have put here just the COVID virus and the vaccine, that we have problems in this group who are B-cell depleted, that they don't respond to the vaccine, they don't respond well to the vaccine. So just to mention the last trial, the Rituximab trial is also a randomized multi-center trial comparing rituximab with azathioprine in maintenance therapy in relapsing patients. So there you have the relapsing phenotype as opposed to the main Rituximab trial, where you would include patients that maybe would never relapse. So this is the protocol and the trial. So every patient was induced with rituximab and then randomized to either azathioprine 2 milligrams per day or rituximab 1 gram every 4 months until month 24, when all treatment was stopped. So here are the results. The time to the first relapse is significantly better in the rituximab group, and the number of adverse events is fairly similar in both groups. So interestingly, there's not much difference in hypogammaglobulinemia in this between rituximab and azathioprine. Let's see here. Rituximab that was then superior, and the relapse rate at 24 months was much lower. And between the groups, you could not also, apart from the hypogammaglobulinemia, there were no differences in infections between the two treatments. So, but what happens here after you stop the treatment is that the patients relapse. So rituximab is not a cure, it's a treatment for maintenance. So I just want to say very briefly about Pexivas, because we all know about this was the biggest ANCA-associated vasculitis trial, which showed that patients with GFR less than 50 randomized either plasma exchange or not, that plasma exchange didn't improve outcome. But the reduced dose of steroids or glucocorticoids was a positive outcome, as it didn't seem to make much of a difference if you used a higher or lower dose. And but it had an important impact on fewer infections if you use the lower dose, 0.5 milligram per kilogram. So there is an ongoing new meta-analysis looking at Pexivas, and there will be a new take on when to still use plasma exchange in ANCA-associated vasculitis. So some people interpreted this trial that now we should stop with plasma exchange, but I think many nephrologists have felt a bit uncomfortable with this. So there will be new information, a new meta-analysis, and new advice on how to consider plasma exchange in our patients, but it will not be the ones with 50 in GFR. So the conclusion is that complement inhibition is likely to be included in standard of care in the future, depending on our approval. But is it useful only for induction? Is there some indication to continue with complement inhibition? I think we need a new trial for that. And MMF could be an alternative for induction. I had a lot of patients in this trial, so it was very strange because we didn't have to meet the patient as much because they didn't come for infusions. But it may be that this should be more for MPO positive patients rather than PR3 positive patients. And Rituximab is well established as an induction and maintenance treatment, but cyclophosphamide is still not a bad drug, and I still use it for first treatment. And then plasma exchange. We have to look at this again and see when to use it or not. So thank you for the attention.
Thank you very much, Annette, and also thanks to both speakers for keeping so well on time. And I will again ask the audience to come up with more questions in the chat. While waiting for those questions, we will turn over to the panelists. And I will first call on Kültigin Turkmen, who will comment on the lupus treatment.
Thank you, Marten. Thank you for your excellent presentation. As you mentioned, we know now that belimumab is very effective in induction therapy of the lupus nephritis. However, we have a very important issue regarding cost of these new drugs like belimumab or voclosporin. So most of the governments do not pay money for these new drugs. So I would like to discuss with you that to whom and in which circumstances should we use belimumab? Should we choose belimumab in advanced or refractory lupus nephritis, or should we use this drug in the first line?
I mean, those are very important questions, and I think they mostly depend on the healthcare setting where you are, what to do with that drug. I think if you live in a country where reimbursement is no problem, it may be fair to give the patients from the beginning a better chance to achieve remission. But we have to remind here that we are not speaking about death or dialysis or, I mean, end-stage kidney disease. Here we are speaking about endpoints that include somehow proteinuria, and probably if you give your patient a salt-free diet and ACE inhibitor, you can also very well reduce proteinuria. So, I mean, it's not really what is relevant still. I mean, we are happy for these trials, but they don't really answer the question, can I keep my patients away from dialysis, because this was not studied. So that means if you give belimumab in the first episode of lupus nephritis, you increase its chance by 10–20% to reach such a primary endpoint, of which we still don't know what that means on the long run. So it's certainly better to have less proteinuria. So if you live in a healthcare setting where belimumab is not reimbursed, or it's a cost issue anyway for your hospital or for whomever that pays in the end, at worst the patient himself or herself, then I would select those patients that have already had several episodes, because the main mechanism of action of this drug is to reduce autoimmune disease activity and to prevent these breakthrough flares. Obviously, I would not consider it for the patient that has a refractory lupus nephritis because didn't take the pills. Yeah, I mean, many of what we call a refractory lupus nephritis simply didn't take their MMF or whatever. So, of course, not for those patients, but there are obviously patients that with whatever treatment you use, they still come back with relapses of the disease. And I think for those patients, belimumab may be a solution to prevent the flares on the long run. But obviously, it's not. Its major strength is not an antiproteinuric effect or a specific effect on the kidney. That's why it also applies a lot for those patients with strong systemic, non-renal SLE manifestations, skin, joint, fever, heart, lung. Those patients may anyway receive belimumab already from the rheumatologist. Then I would not object as a nephrologist.
And I would like to ask you about some important data from DAPA-CKD trial. You mentioned SGLT inhibitors may decrease the progression of CKD. What do you think in the near future, are we going to use SGLT2 inhibitors in the treatment of lupus nephritis?
Yeah, I think among all of us, there are conservative people and there are people that like to do new things. I don't know if now you would start to prescribe an SGLT2 inhibitor for lupus nephritis, if this is conservative or if this is innovative, I don't know. But I would certainly discuss this option with my patients because I think we are all impressed by the efficacy of SGLT2 inhibitors to reduce renal and also cardiac endpoints. And I think what is important to remind that every patient with lupus nephritis has kidney abnormalities more than 3 months, so is a CKD patient, right? And yes, we also have learned from the ACE inhibitors, if you start early, you can have big effects. If you start late, you may still see small effects. So means all my young lupus nephritis patients one day will be old lupus nephritis patients, and I hope they won't be on dialysis even in 20 or 30 years. So this I see as my job, and for that I think SGLT2 inhibitors can do something. They will also reduce proteinuria if we love so much to focus on that. Also there they will do some job, but they won't prevent the next lupus flare. So obviously this can only be an add-on consideration. It should not replace any of the other immune modulatory treatments that are important in such a systemic disorder.
Thank you.
Thank you very much, Kültigin, and hopefully you can come back later and comment on the questions from the floor. But now I will hand over to Dimitrios to comment on Annette's talk on ANCA-vasculitis.
Thank you very much, Mr. Chairman. Annette, thank you very much for the excellent lecture, reviewing all the recent trials on treatment on ANCA-positive vasculitis. I have a comment on the maintenance therapy with Rituximab. We know that it is an established maintenance therapy at the moment because it's better than azathioprine, as you very well showed to us. But I think there are still pending matters in the use of Rituximab as maintenance therapy. Which regimen is the optimum? How long is the duration of maintenance therapy with Rituximab in order to avoid relapses and in order to balance with the possible danger of an infection? So I think it's still pending, and maybe a new trial comparing the regimens and the duration of treatment might be useful. What do you think?
Yeah, so this is like $1 million question. That's the problem we all have, is that it's an effective drug, but should we go on forever or should we stop? And the biggest issue is that we should have better biomarkers to know that we could guide treatment. I mean, of course, ANCA is one thing, but we need better tools to guide us. Who will be a high risk of a relapse and should continue forever, and who could we stop and wait? So the main Rituximab trial, one of them was to give patients Rituximab. One group was given Rituximab fixed dose, and then the other group was given this on demand. If the ANCA went up or something happened that would indicate a relapse, I mean, prior to a relapse. And the group that was not fixed, they received less Rituximab in the end. So that could be, and I think both methods are used, for patients and for the physician, it's much easier to have this fixed dose and you know when to plan it, but you have to consider the disease mechanism and the biology more, I think. It has to be more sophisticated and it has to be personalized more. And now with the COVID-19 pandemic, it's been a real issue with Rituximab. It's really it also increases the risk of severe infection, and it's a big problem when it comes to vaccination.
Right. And my second question is on the induction therapy. Of course, Rituximab is not inferior to cyclophosphamide, but in the clinical practice, we usually individualize the treatment. If we have a patient with severe disease, let's say lung involvement, severe histological findings with many crescents and a lot of necrosis in the tissue, and serum creatinine increasing more than 4 milligrams per deciliter or needing dialysis, we usually treat him with cyclophosphamide because there is more experience and we prefer it. If we have a patient with, let's say, less aggressive disease, or a young woman, as you said, for fertility, or an elderly people, we might go for Rituximab as induction. Concerning plasma exchange, if there is a lung involvement with hemorrhage and this type of issues, might add some plasma exchange. This is the usual clinical practice. You know it very well. We have to differentiate these basic principles in our clinical practice concerning the new information from the data that come from the last studies.
Yeah, so there is this idea that ANCA-associated vasculitis if you have just localized involvement, like these are the patients that we rarely see because they are the rheumatology patients. But even in those patients, I would say that you should have real induction because the old trials like NORAM showed that methotrexate didn't do as well as cyclophosphamide for induction. So I think you have to look at the patient. And also I think we had a study that Marten initiated about elderly, and it turned out that the elderly were not really well treated because everybody had this idea that we should be careful and not give them that much treatment, and then you under treatment. But I think what is really important now is that the role of steroids, that we can reduce the dose, which is also in the Rituximab trial, is really interesting because there you could choose which dose to give if you wanted to give 1 milligram per kilogram or 0.5 milligram per kilogram. And I think 70% of patients had this lower dose. So we will feel more comfortable with using the lower dose because steroids really drive the side effects with regard to infections. So I think that you really have to treat the patient for new disease or a flare. You have to treat them well, but you can still modify some of the drugs. As for the first treatment, I also feel more comfortable with cyclophosphamide, especially very sick patients. Or you could also perhaps combine, which was done in the Rituximab trial, Rituximab and cyclophosphamide, and in that case, reduce steroids as well.
Thank you.
Well, we have now come up to the time when we can have questions from the floor, and I think that we can continue with some questions regarding ANCA vasculitis. There has been questions here about the use of Rituximab for maintenance. What schedule do you prefer? Annette, you mentioned something here, but people here are interested in your personal opinion here.
So I think the Rituximab trial was sort of special. It was this relapsing patients. This 1 gram, I don't think it's called for. The main Ritzen trials really point to that 500 milligrams every 6 months is fine. Probably you could reduce it. I mean, you could prolong the interval. Most patients have their relapse at exact same time. So if it's like after 1 year, they will have it after 1 year. But right now, I would say 500 milligrams every 6 months as a maintenance therapy.
That's actually what we use also at our hospital. So how do you do now with the vaccination? Do you prolong it even more in stable patients, or do you treat and give them vaccination regardless where in the cycle they are?
No, it's a really big problem. I had clinic, I think 10 days ago at Karolinska, and I had 10 patients I checked antibodies, and one had sort of little bit above the positive line. And 6 of them were transplant patients, and the rest were rituximab. None of them, I mean, only one had antibodies. And we had prolonged it. It was 7 months, and we really tried. But I think you should prolong it longer. And there's a paper that was published, I think, yesterday or the day before, from a center in Switzerland, in Bern, Matthias Mohr, and they looked at circulating B cells and also CD4 cells that could then predict the response. That it seems that it would be a better idea to wait. So I think that we have to wait for 9 to 12 months. And if you have a stable patients, you could probably do that.
And there is also another question coming up here about the biomarkers, the B cells, CD20 positive cells. Does that influence your? Do you count them before determining vaccination? Do you think that is predictive of response to vaccination?
Yeah, it seems like the data from Switzerland points to that. I mean, we took a long break and didn't check for CD19 cells but now with the COVID and vaccination, so I think it's a good idea to check it before you give them the vaccine. And if they're not positive, probably should wait even longer. The response rate seems really low otherwise. And there's also been a small study on booster doses from Johns Hopkins, and it doesn't seem like it does a great job either, as opposed to for the transplant patients. That seems to be better.
And one final question now before we go back to lupus here is that regarding the MMF and the question that do you really use it now for maintenance in your patients, and would you do that with patients also on rapidly progressive glomerulonephritis?
Yeah, so that study, the MySac study, it seems like it started in 2012, so it's a long time ago. I actually, with considering COVID and everything, if they have a relapse, I try to start with MMF, and if it doesn't work, I have to rethink it. But I think it in some patients that are MPO positive, and it's difficult for them to come to the hospital and all that. It could be a practical thing just to give them MMF instead of having them come for cyclophosphamide or infusions or rituximab infusions. But you have to consider the situation of the patient, but it's an option. It could be useful.
Why should, from a theoretical standpoint, why should MMF be better for induction when it's actually worse than azathioprine for maintenance?
Combination with the induction of corticosteroids and the acute. It's really kind of difficult to completely compare the situation, but I mean, we all use MMF as maintenance also if people can't tolerate azathioprine. So I don't know. I think it's a matter of practicalities more, which kind of induction treatment you will use right now, especially.
Thank you, Annette. And I will turn to Achim again. We got questions here on the use of voclosporin. And one question was, can it be used also in patients with low GFR? Do you have any experience or any knowledge there?
Yeah, it's important to realize that in the trial, patients had not been included with GFR less than 45 at the beginning. There was always the concern that GFR could drop, like we know that from other calcineurin inhibitors. That's also why the package insert in the US notes that if GFR drops, you have to reduce the dose. So the voclosporin is interesting, is formulated in pills of 9.7 milligrams. And for the full dose, you have to take 3 pills in the morning and 3 pills in the afternoon. So when GFR drops during the treatment, it's recommended to reduce the dose from 6 pills to 4 pills a day. But if the patient has already an advanced CKD, voclosporin may not even be an option to start. But we have to also say that lupus patients are usually young females. So that means in the first episode of lupus nephritis, usually they have a normal GFR. unless it's already a very advanced and very severe SLE and diagnosis is delayed and so on, that you see the patient with already low GFR in the first place. But then, of course, there are the patients that had already several episodes in the past and they are already in the middle of CKD progression and then have a flare. This can come to a situation where voclosporin is no longer an option according to the label. But this is still in the future for Europe, but in the US, this package insert specifies this. And it's a bit of similar to what we know from ACE inhibitors. I mean, that you have to do it GFR before and then monitor it while you start the treatment. Although in the trials, trials has not yet been observed that there is really a GFR drop, but there was still the concern that this might happen. And that's why the recommendations in the package insert are this way.
There is also another question regarding voclosporin, but in the other end of the GFR spectrum, those with less changes, less proliferative changes, the class 1 or class 2, also considered as lupus polycythopathias. From your talk, I got the impression that you maybe would favor those patients for this treatment. Is that correct? And do you have any knowledge if it's been tried also outside the lupus area for similar diseases?
No, interestingly, voclosporin has been used only for very selected disorders for the moment. And up to now, there are no studies reported in, let's say, minimal change or FSGS. The biopsy the class of lupus nephritis is, these trials have been done as usual, included 3, 4, 5. So lupus nephritis class 1 or 2 have not been included. Usually we would not consider any immunotherapy in these kinds of patients unless the patient has a clear podocytopathy, means large amount of proteinuria, and then in the biopsy there's almost nothing to see. So let's say class 2 with nephrotic syndrome, this is something that we see from time to time. And these are patients where probably the lupus is not the main problem, but the patients have a very sensitive filtration barrier due to probably genetic reasons. So these are patients that rather are more similar probably to minimal change patients than to lupus patients. So here you would treat the patients according to minimal change, basically with steroids or drugs that replace it, Rituximab to spare steroids, and this is also what the KDIGO guidelines will come out with, that if you have a class 2 plus nephrotic syndrome, or maybe even a class 1 with nephrotic syndrome, should be treated according to idiopathic nephrotic syndrome, because there's no need to treat the SLE in these patients in terms of the kidney, but you have to treat the nephrotic syndrome yeah. So that means here voclosporin for the moment has no role, even though there may be a good rationale for that. But for the moment, the sponsor, the company, didn't launch any of these studies, at least nothing yet reported.
So in other words, it seems reasonable, but it's not supported by the company or the data.
Yeah, I mean, there may be reasons to switch to voclosporin once it becomes available, because I mean, we are used to use calcineurin inhibitors in these settings to spare steroids, and at least voclosporin doesn't seem to come with these metabolic side effects, diabetes, lipid changes, and so on. So it seems the safety profile of voclosporin is so much better than the other calcineurin inhibitors. So that may be a good reason actually to use it or to replace the other calcineurin inhibitors, but no data. So I mean, this is a good rationale to do a study, and not necessarily to recommend it to the public now to do it this manner. This obviously also applies to what I said about SGLT2 inhibitors, and no studies. Lupus patients were excluded from the DAPA CKD trial. So it's not that now I recommend to do it, but I mean, one may consider it. And then it's everyone on its own shoulders. But obviously, new studies would be better to have.
Well, we have many more good questions coming in here, but I'm sad to say that it's now approaching 6 o'clock, and the time for this seminar webinar is over. I would like and encourage everyone, though, to stay tuned because you will be diverted to a short feedback survey that we are very interested in getting the results from. And I would also like to mention here that the next IWG seminar will take place on the 23rd of September, and it's organized by the Eureka Working Group, and it's talk to how to target blood pressure in CKD in the post-sprint era. Is the name of the title. With this, I would like to thank all the speakers and the panelists for very, very nice and interesting discussions and very good talks. And also for this large audience that have listened. We are very happy for that. Thank you all.